Our case was treated with transarterial chemoembolization, or what we call TACE, based on the treating team multidisciplinary decision at the time. If we calculate the Child-Pugh classification of this patient, he will fall under category of class B because of the bilirubin of 3 and the mild ascites. So it's a gray zone based on the fact that most of the randomized clinical trials, whether systemic or localized, they focus on patients with Child-Pugh A class. However, it reflects the real life scenarios where treating physicians in community settings are faced with patients with underlying liver disease and typically with Child-Pugh B in a significant number of cases. So they proceeded with selective TACE for this patient based on the fact that it was a single tumor and the patient performance status was excellent. Restaging at 1 month revealed that the patient did not have a good response to TACE procedure, which is not totally unexpected in this very specific scenario for 2 main reasons. Number one, the size of the tumor. And basically that takes us back to 2002 when the TACE procedure was approved for HCC, and the 2 major studies that approved it were relying on a patient population with average tumor size of 5 centimeter in one study and 7 centimeter in one study. So beyond 7 centimeter, typically patients need more than 1 session of TACE. Additionally, patients with advanced liver disease, Child-Pugh B, in general don't respond very well because their liver function status. So these 2 factors here probably could have contributed to the lack of good response in our patient. The treating team decided to start systemic therapy for our case today in the form of lenvatinib at 12 milligram daily. And that takes us to the very important question, which is basically when to start systemic therapy and the choice of systemic therapy. So in general, systemic therapy for HCC is indicated in case of metastatic disease setting, in case of major vascular invasion and imaging to portal venous system, for example, or hepatic veins, or in case of lack of response to localized therapies. So patients who are not candidates for surgical resection or transplant and either did not respond to local therapy or not local therapy candidates, they go on systemic therapy. So this patient followed this train of thought and was started on lenvatinib at 12 milligram daily. However, 3 months later, the patient did not respond based on imaging. So first is a big question, which is which agent to start with. Currently, FDA approved frontline therapies in HCC are limited to 2 drugs, sorafenib and lenvatinib. So if you follow both studies that approved both agents, they had almost identical inclusion-exclusion criteria, and then lenvatinib was approved based on a non-inferiority study design against sorafenib. In general, patients, this decision to start patients on which agent is really dependent on the specific practice. So there was a meta-analysis published in JCO a couple of years ago that looked into this question for sorafenib at that time and looked into a pooled meta-analysis of all phase 3 studies of sorafenib and concluded that patients with hepatitis C benefited the most from sorafenib. There is also subset analysis of lenvatinib phase 3 study against sorafenib that suggested a trend towards a better benefit with hepatitis B patients on lenvatinib. The study was not powered enough to really answer that question. However, these trends led a lot of practices to tailor the treatment based on the hepatitis status. So for hepatitis C, for example, a lot of physicians start with sorafenib. For hepatitis B, a lot of physicians start with lenvatinib. Also, one of the determinant factors is whether any response of the tumors to therapy would change their course of management. So for example, if you look at the lenvatinib versus sorafenib study, the response rate was much higher on lenvatinib than sorafenib. In fact, the independent radiologic assessment based on modified RECIST showed up to 40% of response to lenvatinib. So if the patient responds in terms of partial shrinkage of the tumor could change therapy decisions, some physicians also start on lenvatinib. However, we have to be careful in this era of strong anti-angiogenesis drugs such as lenvatinib in frontline and other drugs in second line about the potential adverse events in patients with portal hypertension and large varices. So in my practice, I always start with upper endoscopy before initiating anti-angiogenesis therapy to make sure we evaluate the varices, and if they are at risk for bleeding, we address that before we initiate therapy.